So I'd like to introduce Nirvana. She is a fellow who's just completed her time at Chris Hani Baragwanath Hospital, and she'll be giving us an update on idiopathic inflammatory myositis.
All right, so good morning. Today we're going to be discussing an update on idiopathic inflammatory myositis. So the topic for today is centered around the following case. There we go. So we have a 33-year-old female. She was HIV positive. She presented to Baragwanath Gynae department with abnormal uterine bleeding. Her initial assessment based on clinical examination was a suspicion of cervical carcinoma. She had a 6-centimeter palpable mass. She was then admitted for a biopsy, which confirmed the diagnosis. She had a staging CT performed, and she was planned for chemoradiation therapy. Upon discharge from gynecology, it was noted on her discharge summary that the patient had reported joint pain in both hands, and that she was then referred to hands OPD for an initial assessment a week later. So 2 weeks later, she was referred to rheumatology after being reviewed at hands with the main complaint of arthralgia in her hands and elbows with associated early morning stiffness. On further inquiry, she also noted joint swelling. She also had swelling around her eyes, a new rash that had developed around her elbow and knees, and that had begun around the time of the abnormal uterine bleeding in February of 2023. On further probing, she reported difficulty with climbing stairs, combing her hair, and lifting herself off a chair. Our initial examination findings was that she had this puffiness around her eyes with a scaly erythematous rash. Just trying to get the pointer. So she had a rash around the eyes, quite subtle with hyperpigmentation and scaling. For fingers, it's a little bit more difficult to appreciate, but she had a hyperpigmented rash over the MCPs with a scaling texture. She had a new rash that had developed on the posterior aspect of her back. She also had the similar appearing rash on the extensor surfaces of her elbow as well as her knees. And this was also visualized on the lateral aspect of her thigh. Her neurologination revealed proximal muscle weakness in the form of upper limb power proximally of 4 out of 5 and a lower limb power of 3 out of 5. She also clinically had evidence of neck flexion weakness. She had synovitis of the knees and ankles as well as her MCPs, and her other systems examination were normal. So in summary, we had a 33-year-old female who was HIV positive. She was virally suppressed on treatment for 3 years. She was newly diagnosed with cervical carcinoma, awaiting a DXT. She now presented with proximal muscle weakness, a heliotrope Shaw sign, Gottram's papules, and a Holster sign. And our clinical concern was that of a cancer-associated dermatomyositis. So that leads us to our topic for discussion today, and that's an update on idiopathic inflammatory myositis. So inflammatory myositis is a group of disorders which is characterized by proximal muscle weakness. This is driven by autoimmunity, and it has quite a heterogeneous presentation. So patients may present with pathognomonic rashes in the context of dermatomyositis, present with so apart from, but in the absence of this is what we're going to be unpacking today. So many of you may be familiar with the original classification criteria 1975, which is Peter and Bohan criteria. This looked at 5 parameters, and it was evidence of muscle weakness, so the particular pattern of weakness being more proximal, together with very elevated CK, EMG abnormalities, and muscle biopsy findings that were specific to the disease. Patients needed 4 of these to be classified as poly. If they had 3, they were labeled as probable polymyositis. In the presence of a rash, you needed 4 or 5 criteria to be diagnosed as dermatomyositis. So fast forward about 40 years, we now have the much more extensive 2017 ACR-EULAR classification criteria. So although it's not important to commit these criteria to memory, particularly because it's difficult in that it's a points-based criteria, what is important to understand what warranted the change in these classification criteria. So looking a bit more in detail at our disease, it's a rare disease with an incidence of 2 to 19 cases per million. Dermatomyositis has slightly increased frequency towards the equator, and it has a bimodal age distribution with a peak in juvenile patients between the ages of 5 and 15, and again later on between the ages of 45 and 65 years old. Polymyositis is increasingly rare in terms of us making the diagnosis because of new antibodies which we have, and accounts for under 5% of idiopathic inflammatory myositis. It's rare in our juvenile population with a mean age of onset between 50 and 60 years old. As with many of our rheumatic diseases, there is a female predominance of 2 to 3:1. And if patients have an associated connective tissue disease as an overlap, so lupus, Sjogren's, or scleroderma, the female to male ratio increases from 8 to 10:1. In our American studies, there's a slightly increased frequency of diagnosis in African-American patients as compared to Caucasians. So how would we approach this patient when we encounter them on the first clinical visit? The first thing is a good history taking. Early on, patients may report more subtle symptoms, and they may describe it more as fatigue. And these can be things subtle as difficulty getting off the toilet, having to hold a railing when walking upstairs, to a point when it progresses to quite subjectively obvious clinical signs such as clinical symptoms, and that would be difficulty coming out of a chair, climbing upstairs, doing their hair, and hanging clothes, picking up their kids. Together with this, we need a thorough clinical examination. The important clinical questions to ask is, what is the pattern of weakness? So we would identify that the weakness is more proximal than distal. So that would be particularly your shoulders, abduction and flexion, hip flexion as well. Once we've identified that the weakness is more proximal than distal, we want to be able to do a full thorough neurological examination and ensure that this is the result of a myopathy as opposed to any nerve-related complication. If we've identified now that our patient has proximal muscle weakness, apart from inflammatory myopathies, we need to consider other differentials. So this is important not to forget because it would affect how we would treat our patients. So drug and toxins can cause acquired myopathies, particularly corticosteroids. Statins can cause a host of muscle manifestations, right from myalgia to a severe presentation with profound muscle weakness, elevated CKs. This tends to happen a little bit more acute to subacutely. And with statins in itself, there can be induction of antibody formation, and patients may have a more prolonged course of disease. Alcohol can cause an acute myopathy in the context of rhabdomyolysis, or may cause a more chronic picture. We also want to look for clinical signs to suggest an endocrinopathy, so hypo and hyperparathyroidism, as well as not to forget miscellaneous diseases such as sarcoidosis, which can cause both acute and chronic myopathies. In the adolescent population, we also don't want to forget our hereditary causes, such as limb girdle or facioscapulohumeral dystrophy. So particularly when you see a patient presenting at a younger age, your clinical examination is important. Once you've ruled out your acquired and hereditary causes, you then consider your subcategory of your immunoinflammatory idiopathic myositis. Apart from your musculoskeletal system, you're going to do a thorough cutaneous examination. You're looking for pathognomonic rashes, and that of the heliotrope rash. This is described as a purple or lilac-colored rash that occurs over the eyelid. It may be associated with periorbital edema. And the pictures below just depict that these rashes can occur quite differently in patients of different skin tones. So in lighter skin patients, you often see a very erythematous violaceous rash, which is very clinically apparent. But in our darker skin patients, it may be subtle hyperpigmentation and scaling of the skin. And this is often a sign which may be clinically missed if not looked for. Other skin manifestations is that of Gottron's papules, an erythematous or violaceous rash which occurs on the extensor surfaces of joints. It's a raised rash, and it may occur over the fingers, the elbows, over the knees, and malleoli. And again, in lighter skin patients, it may appear more erythematous. In darker skin patients, it may be more a hyperpigmented scaling appearance. When you see this erythematous violaceous rash, but it's more flat in nature, so not raised, so macular, we call it Gottron's sign. Other manifestations, and these often are in sun-exposed areas, is that of the shoal sign, which occurs on the posterior aspect of the back. Again, erythematous or hyperpigmented scaling in nature. On the anterior aspect of the neck, we get a V sign. On the lateral aspects of the arms, we describe a sleeve sign, and on the lateral aspect of the thigh, a holster sign. Patients may also have the presence of calcinosis, and that can occur on their finger pads or around joints, and that occurs a lot more commonly in patients with juvenile onset of disease and may be quite difficult to treat. And as with many of our connective tissue disease, Raynaud's phenomenon may occur as well. The nail changes in patients with dermatomyositis are quite important in that they develop periungual erythema. It's a sign of a vasculopathy, which is one of the important pathogenic mechanisms of the disease. Patients may also have ragged cuticles, and on close inspection of their nail folds may have evidence of hemorrhages and infarcts and specific nail fold capillaroscopy changes. So together with our cutaneous manifestations, what is important to assess on first presentation is, does the patient have features of severity? And so that would be asking and looking for a history of dysphagia, difficulty with speech, evidence of neck flexion weakness, as well as respiratory muscle involvement. The importance of identifying these features early on is that this would not only necessitate peak-flow monitoring, but also that this particular patient would need to be monitored in a high care or ICU setting. Apart from assessing severity, we also want to look for signs of other systemic involvement, so joint involvement, features of interstitial lung disease, as well as cardiac involvement. Once we've clinically assessed our patients, what laboratory investigations are we going to do? And the first would be to look for evidence of muscle injury. And in that, we can do a creatinine kinase. There's a very small percentage of patients who may have a normal CK, and in that context, we could pull an aldolase level as well. And we would also look for other surrogate markers of muscle injury in the form of an LDH, an AST, and an ALT. The current classification criteria also speaks to antibody testing, particularly of anti-JAH1. And this is an antibody which is specific to inflammatory myopathies. But is this the only antibody that we have? And that brings us to discussion about antibodies in the context of inflammatory myositis. So that is one of the reasons why the criteria changes, because over the years, there's been a lot more evidence of how antibodies play a role in disease development and how these antibodies predict a phenotype with which a patient will present. So we have two groups of antibodies. We have myositis-associated antibodies and myositis-specific antibodies. The myositis-associated antibodies may occur in the context of other connective tissue diseases. So they're not specific to inflammatory myopathies. They can occur in about 40% of patients, and they can occur in conjunction with other antibodies, so myositis-specific antibodies. Examples of these are ANA, anti-Rho, anti-Q, and PMSCL. And patients may have overlap connective tissue disease, as we mentioned, in the form of systemic lupus, Sjogren's, scleroderma. Our myositis-specific antibodies are specific to inflammatory myopathies. They can be present in up to a third of cases and are mutually exclusive. The importance of these antibodies is that they help us to predict what extramuscular manifestations the patient may have. We can anticipate the patient's prognosis, and that then guides the aggressiveness of therapy that we're going to institute for our patient. So this diagram depicts the range of myositis-specific antibodies that we have. The important points are that we have antibodies that predict a more severe course of disease. So anti-SRP is often associated with very severe myopathy and dysphagia. It would warrant more aggressive immune suppression at the onset. And HMG-CoA is also associated with a more necrotizing form of myopathy. So on biopsy, there would be a paucity of lymphocytic infiltrate and more muscle necrosis. And anti-HMG-CoA antibodies may also be induced in the presence or in a patient who's using statins. So these two antibodies would predict a more severe course of disease. We've already mentioned the antibodies associated with connective tissue disease, and we have antibodies that are associated with typical features or skin manifestations of dermatomyositis, particularly anti-MI2, and these patients are labeled as classical dermatomyositis and tend to have a better or more responsive disease course. The two sets of antibodies I'm going to focus on are those that are associated with lung manifestations and those that are associated with malignancy. And the reason being is that these two extramuscular manifestations can also increase our morbidity and mortality in our patients. So when looking at interstitial lung disease and myositis, this can be a whole topic on its own, but just to summarize, we have the antisynthetase syndrome. So these patients have inflammatory myositis and with interstitial lung disease, and the context of antisynthetase antibodies. These are tRNA histidyl antibodies. They tend to present in a specific phenotypic way with the presence of mechanics hands, where they have a scaly hyperkeratotic rash on the radial aspect of their second and third digit. They often report Raynaud's phenomenon in association with fever and may have inflammatory arthritis as well. And there are about 8 antibodies within the subgroup, of which we are able to test for anti-JAH1. Again, identification of the subgroup of patient would warrant aggressive immunosuppressive therapy because of the presence of interstitial lung disease, which can result in significant morbidity for our patients. The anti-MDA5 disease or anti-melanocyte differentiating antibody is present in patients with inflammatory myositis, and these patients tend to have very rapidly progressive interstitial lung disease. Patients typically get these very specific ulcerative lesions, which can happen over the MCPs, the PIPs as well. They may also happen on the palmar aspects of the hands and in the oral mucosa. They also get very pathognomonic palmar papules, which occur on either side of the finger creases. These patients may present in an amyopathic subtype, so where they have the typical rashes with interstitial lung disease, but don't have clinically apparent muscle weakness, and they may also have very severe skin disease. There's a higher mortality associated in the subgroup because of the progression of the ILD is very aggressive, and again would warrant more aggressive immune suppressive therapy at disease diagnosis. With respect to malignancy, anti-NXP2 and anti-TIF1 gamma are antibodies which are associated with inflammatory myositis and malignancy. The incidence as a group within idiopathic inflammatory myositis of malignancy is higher in that it can occur in 10 to 20% of patients, and particularly in older patients, with patients over the age of 65 up to about 50% having malignancies at diagnosis. The risk in dermatomyositis is about 3 to 6 times higher. So certainly more than patients with polymyositis, where the risk is about 1.4 to 2 times higher of malignancy. 2/3 of the malignancy is diagnosed within the year of diagnosis of inflammatory myositis, and generally most cancers would be clinically apparent within the 3 years before or after diagnosis of the inflammatory myositis. As we mentioned, TIF1 gamma and NXP2 are associated with adult cancer-associated dermatomyositis, with JO1 and MI2 antibodies having a negative association. And this again highlights the value in being able to test for these antibodies, because it would also be able to streamline what investigations we're going to do for these patients. Patients with ulcerative skin lesions also have a higher association of having an underlying malignancy. So the type of cancers that we're seeing are large variety in terms of adenocarcinomas, particularly ovarian, breast, lung, pancreas, or stomach. Patients may have hematological malignancies, and in certain subsets of patients, like Taiwanese patients, there's a higher incidence of nasopharyngeal or cervical carcinomas. So what screening is done, at outset, it would be a thorough history and physical examination, and you would want to use that, particularly if there's something suspicious on history or exam, to guide what investigations you're going to do. If there's nothing clinically apparent, you would want to do a chest X-ray, a mammogram, and a pap smear. Assess if the patient is appropriate for a colonoscopy and possibly stool occult blood testing, particularly if there's an associated anemia, and your full laboratory panel as well for looking for any signs of malignancy. If the initial cancer screen is negative, within that next 3 to 5 years, you want to repeatedly screen your patient for malignancy. So depending on how you risk assess every 6 months to a year. Because of our limited resources, we would do these basic investigations and what screening we can do. In certain centers internationally, they are doing CT scans at the outset, and depending on resources, some centers are considering PET scan at the outset, particularly if your antibodies are positive for NXP2 or TIF1 gamma. So with the discovery of these antibodies, it begs the question of whether muscle biopsy is still relevant in these patients, in that we can use the antibody to determine the phenotype and the progression. Is there utility to the muscle biopsy? And the answer is yes, in certain clinical scenarios. So particularly when a patient is not presenting with typical rashes or typical extramuscular manifestations, and you're suspecting a polymyositis, muscle biopsy would be useful because we don't want to miss certain subcategories. And these are your immune-mediated necrotizing myopathies and patients with inclusion body myositis. So inclusion body myositis differs from our other idiopathic inflammatory myositis in that it presents quite differently. It occurs more commonly in male patients, patients who are older, around the age of 50, and patients have a different pattern of weakness. So they predominantly have more distal weakness of finger flexors, as well as your wrist extensors. They get distal wasting, and it tends to be a more insidious onset of disease and poorly responsive. On biopsy, they would have more rimmed vacuoles. So there may be utility where your patient's not responding to treatment and they're presenting with certain atypical features. Important to note is that a patient who has typical skin rashes with evidence of muscle injury That is enough to diagnose a patient as having dermatomyositis and initiate therapy. If you do biopsy your patient, what are you seeing? So in polymyositis, you'd see endomysial infiltration. In your dermatomyositis, the inflammatory cell infiltrate tends to be more perimysial and with perivesicular atrophy. And in patients with IBM, there is the appearance of rimmed vacuoles as well. Other investigations that are important at the outset are your EMG. It has a good sensitivity of 85%, but less specific with specificity of 33%. And typical findings that we see are very short motor action unit potentials. They have increased insertional activity or irritability and complex repetitive discharges. MRI has also been used more frequently, and the importance of MRI would be particularly when patients present later on in the disease, where they've had multiple lines of therapy, and you're not sure whether there's ongoing inflammation accounting for their ongoing weakness, or there's muscle atrophy. So MRI can identify areas of active edema or inflammation on the scan versus areas of muscle atrophy. It is also important to identify which areas would be useful to biopsy where your clinical diagnosis is uncertain or patient is not responding well to therapy. So in summary, you put together your laboratory, your clinical and your examination findings, and you would identify a patient with proximal weakness. Patient who is a younger age of onset would be classified as having juvenile onset of their disease. Patients with rashes would be classified as having dermatomyositis. If they don't have overt muscle weakness, they would be clinically amyopathic. Those patients who don't have the typical rashes may benefit from a muscle biopsy at diagnosis. So we can subclassify patients into adult or juvenile onset, immune-mediated necrotizing myositis, and that would be important to get a particular drug history. Inclusion body, as we mentioned, have a slightly different manner of presentation, and not to forget patients who have overlap features of other connective tissue diseases, and that we want to screen for malignancy in our patients, particularly our older patients. So to touch on the principles of management, when you acutely see a patient, you want to assess signs of severity. If a patient has features of severity, you want to try and stabilize your patient and monitor them ideally in a high care or ICU setting. Your specific management would be induction of your high-dose corticosteroids with the initiation of steroid-sparing agent, and your choice of agent also depends on your extramuscular manifestations. So your first line of therapy would be glucocorticoids together with methotrexate or azathioprine. If a patient is not responding, and that we assess with particular activity indices, but essentially looking at their subjective muscle weakness, their objective muscle power, as well as their muscle enzymes. If we see the patient is not responding, we can combine methotrexate or azathioprine, or we can use other agents such as MMF or CNI. And third line therapy for poorly responsive patients would be rituximab or cyclophosphamide and consideration of other biologic agents. With these agents, we may or may not consider the use of polygam. So there's been more research done into use of IVIG in these patients, and it is indicated particularly in patients who have more severe presentations, patients who require intubation, who have dysphagia or pharyngeal muscle weakness at presentation. So management principles in patients with myositis with interstitial lung disease. As we said, the interstitial lung disease is associated with a higher morbidity and mortality in the subgroup. So those patients who at onset have more severe disease, we would use intravenous glucocorticoid pulse therapy together with more potent immunosuppression, so in the form of cyclophosphamide or rituximab. Depending on the response, you would also initiate a glucocorticoid sparing drug, such as MMF or azathioprine, with more use of your CNIs as well. And if your patient is poorly responsive, you would then either consider combination of these therapies or switching to the alternative, depending on what you've used at onset. Patients with more mild disease, you can initiate an oral DMARD in the form of MMF or azathioprine, again, watching closely for their clinical response. Always to remember that these patients are poorly mobile. So particularly when they're in hospital, you want to use low molecular weight heparin prophylaxis, rehabilitation, psychology for the chronicity of the disease and the difficulties they face, and assess that whether these patients require disability grant. In the context of patients who have paraneoplastic or cancer-associated dermatomyositis, the key is to as early as possible, identify the malignancy and to treat the malignancy. The prognosis in these patients is often dependent on that of the underlying malignancy. These patients do respond often to high-dose corticosteroids, but may not achieve a full response until the malignancy has been treated. So in summary, in terms of looking at our patient, we had a 33-year-old patient. She was HIV positive, virally suppressed. She had been diagnosed with CA cervix and was awaiting DXT. We had features of paraneoplastic dermatomyositis in the form of the proximal muscle weakness and the typical rashes. Because she also had a bit of dysphagia when she came in, she was initially pulsed with intravenous corticosteroid therapy, 500 milligrams for 3 days. She was then switched to oral prednisolone. Chloroquine was initiated for the skin manifestations, and she clinically had a good response on examination, as well as a CK response, which came down from 800 to 157. The decision at that time was that because she was going to be getting radiation therapy quite shortly thereafter, she was maintained on prednisone, and a steroid-sparing agent was to be initiated as soon as she had completed her first round of DXT. So the take-home messages in this case is that there have been many changes that have occurred in the last 40 years, particularly with the discovery of myositis-specific antigens, which has changed how we look at the different phenotypical manifestations of idiopathic inflammatory myositis. The value of testing these antibodies helps us to determine how we're going to investigate patients, how we would monitor, and the aggressiveness of treating these patients. At present, we are able to check for some of the myositis-specific antibodies, and that being JO1, MI2, and SRP. And more recently, at Barra particularly, we've sent specimens off to Stellenbosch to check for MDA5 as well. More tests are available in the private sector, but hopefully in the future, we will have much more easier access to these antibodies to try and better define our patients' disease course and management.
So thanks for the talk. So ask, in terms of the drug-induced myopathies, especially statin-induced, how long after discontinuation of statin should we expect patients' response to improve, or does it depend on which statin it is?
So it doesn't really depend on the type of statin. What they do say, particularly in patients who have had the antibody induced, is that there's a small percentage of patients who may go on to developing chronic disease, and that's because they continue to produce this antibody. So usually within 2 to 6 weeks, you may see a response. You're also giving them corticosteroid therapy at the moment. So it's difficult to sort of differentiate. Is it just purely because you've stopped the drug, or because you're also immune suppressing a patient? And then you would then need to monitor closely and check how they respond in the months to come. And a certain percentage, you may not see a good response, or you may go on to developing chronic myopathy and would warrant lifelong therapy in these patients. If you're seeing a quick early response, it may be a patient who has actually just had a clinical response from cessation of the drug, and then maybe a patient you would wean off therapy a little bit sooner. But it would be almost a long-term trajectory and sort of following them up and seeing how they actually respond. We don't know yet to predict, if you're going to respond on. But with respect to statins, there's different manifestations. I think there's type 1 to 6. So they can just have a myalgia, they can have a raised CK without clinical symptoms, or they can come in with this florid myositis, almost like a rhabdo with severe myalgia, very high CKs. And often those patients tend to be antibody positive as well.
And just in terms of the malignancy-induced ones, like this patient we consider a CK at the initial is 806. Do they always need to be these like ragingly high CKs, or could we even have these crumbling kind of like hundreds,
so
just above the upper limit of normal, so to speak?
So they don't always have to be the raging, and those are also in patients who have a little bit more insidious onset. But in terms of the pathogenesis, what they sort of described is that there's a lot of edema in the muscle, but it's not necessarily particularly immune mediated, not necessarily the inflammatory cells evading around the muscle. There's a lot more tissue necrosis. And so early on, those CKs can actually be not as particularly high as a patient with rhabdo, but they can be grumbling around the thousands and 800s.
Just related to that, how often would the CK be normal? And you suggested you're doing an aldolase in some cases like that.
I'm not sure exactly percentage. So it's a very, very small percent. Generally, would see an elevated CK, but if you still, have a high clinical index of suspicion, you would then do your aldolase as well. And the aldolase, the problem with the aldolase, it also takes very long to come out. So you go on your clinical acumen and treat the patient. and wait for the aldolase result to sort of support your diagnosis. But it's a small population.
That's when you would use your EMG.
Your EMG
muscle MRI. But often in the dermatos, the CK can, the lag between the onset of the rash and the onset of your elevated enzymes will be at least a couple of months.
Just two questions, if I may. They're very different. The first one is, these are antibody. I mean, I think it's now pretty well established. Many of them are antibody mediated. So looking at when you're in serious trouble with interstitial lung disease, etc., plasma exchange with or without IVIG, has that been considered or looked at? And then I was interested because I see quite a few patients. I mean, I'm a nephrologist, and I noticed that there's still a tendency to give chloroquine daily. So during COVID, you remember, we looked at chloroquine and we thought, oh, here we go. And, you know, for the first time in probably 50 years, I think people look properly at the pharmacokinetics of the drug. And it turns out it's actually got a very long half-life and it accumulates. And we see quite a bit of macular toxicity. So I'm still wondering why there's this push to use the drug 5 days a week, 7 days a week, you know, once or twice a week. Has anyone actually looked? Because if you actually talk to the patients, there's a lot of ocular toxicity, which I think we're not appreciating. As I said, they're very different questions.
So with respect to plasma exchange, I'm not familiar with particular sort of randomized trials that have looked at plasma exchange, but I think it has been described in certain cases where patients present in extremis. So often they end up in the ICU with this rapidly progressive ILD. At the moment, there's more evidence, you know, to support the use of polygams. So that's generally what we would do first. But we have had cases in ICU where patients are just not responding with respect to myositis. We give the immune suppressive therapy, knowing that it's going to take a while to take effect. And in those sort of salvage mechanism, you would then consider plasma exchange, but lower down. And with respect to use of chloroquine, so from what I'm familiar with, you know, you should initiate Monday to Friday, and that's to build up the stores. But thereafter, when your patient has had a good clinical response, the ideal is actually to start decreasing the frequency of the dosing. And sort of international recommendation is screening at baseline for presence of any early eye disease before initiation of the drug, and from 5 years onwards. And there's also been a move to using lower doses of chloroquine in these patients as well. I don't know if
so we generally would start weaning by at least 2 years.
Yeah.
Long term, if the patient tolerates the drug and if there's no maculopathy, they would only be on 3 times when they were using it. The reason for using it in your dermatomyositis and affect some of the functions is because it's sleep.
Okay, if I can just go, if I can maybe comment on that.
As for polygam versus plasma exchange, most of the studies now are suggesting that we actually use polygam upfront in multiple severe disease. Your outcomes are far better, whereas if you wait for later, it doesn't have the same. I'm not saying we're going to be asking for polygam or for every patient, but that's what the studies do.
The evidence is there. It's fine.
Because two steps is a particular patient profile that is more at risk of developing myositis, and also with regards to cancers, in particular malignancy, higher likelihood of having myositis as a kind of plastic.
I think with with respect to malignancy, they have seen differences within different ethnic groups. So the Taiwanese or Asian population, it's higher incidence in your nasopharyngeal and your cervical carcinomas. But as a whole, if I'm mistaken, more in your adenocarcinomas, particularly ovarian as well, and breast as well, and breast, lung, ovarian a little bit higher. Yeah. And then the other question in terms of statins and the patient phenotype, I don't particularly think anyone has characterized which phenotype of patient you see it in, and it's something that occurs quite rarely. So I think it would be interesting to sort of pull the data together and actually describe which phenotype of patient. I'm not sure if you have any different experience.
Between myositis and myopathy. Because a lot of them will complain of muscle pain and not an actual elevation in the CK. So I don't think that's why a lot of us have looked at it, because almost every second or third patient has the muscle pain or pain stop.
I know you said most of the time the weakness and the still involved in is symmetrical. Can it be focal? Do you get any focal, just the group of muscles that are involved rather than unilateral?
So within the group of inflammatory myositis, the one that you need to think of is your inclusion body myositis, which can have a more asymmetrical distribution. We said a little bit more distally, but typically your patients tend to present with more symmetrical disease. But again, in the context of specific rashes, even if there's slight asymmetry, you would still be considering it as a diagnosis, but not really like well described as focal myositis.
I think that's the patient to go.
Yeah, biopsy and
Just on got it from which tests would be able to pass that you would want?
So from a race perspective, you'll involve the rheumatologist as well. But what we can, so we would generally, in terms of your myositis associated, we would do an ANA as the outset, and with that an ENA panel. Your myositis specific antibodies on your immunoblot, it would give you your MI2. You can also test for JAH1, and the lab also performs anti-SRP. I think in Stellenbosch, they are doing more myositis specific antibodies. So recently at Barra, there was a specimen sent via the NHLS to Stellenbosch for MDA5. But because these tests are expensive, and I think a lot of them are done more on in a research capacity, you would want to have a higher clinical suspicion before we would be able to justify the cost of the test. So that, and if you really have a strong index of suspicion, you could also look at possibly testing in private laboratories as well. All right, thanks. Thank you. Okay.